Welcome to the Voices of Healthcare Equity. I'm Kim Tranquata, founder and CEO of Healthcare Alliance for an Equitable World, and your host on this journey. Our organization, driven by clinicians, is on a mission to address global healthcare inequity using telehealth solutions. Together, we're building a community of healthcare professionals committed to making a scalable impact on global equity. Join me in insightful conversations with global health innovators as we explore the current and future state of healthcare. Be part of the mission. Let's create lasting change together. Today's episode features my friend, Michael Kurliand, VP of Clinical Quality and Integration at MedWand and adjunct professor of healthcare informatics at the University of San Diego's School of Nursing. Welcome, Michael, and thank you for joining us on the podcast today.
It's a pleasure to be here, Kim, and an honor. Thank you for having me on your show.
Michael, before we begin, I always give our guests the opportunity to disclose any conflicts of interest or any affiliation disclaimers they would like to bring forth. Do you have any you'd like to bring forth?
I have no conflicts, and the disclaimer is this is all my opinion.
Awesome. Well, thank you. If you wouldn't mind, could you tell us a little bit about your background and how you have come to be involved in issues of healthcare and health equity?
Sure. So I've been in healthcare. It's hard for me to say this out loud, but for over 25 years, started out as an EMT, worked as a nursing assistant, and then became an RN, and worked mainly in medical psychiatry and oncology for my first few years, and then ended up specializing in emergency psych and medical psych for the remainder of my years. While I was doing that, some nursing directors thought I was really good at conflict management, so they thought I'd be good at administration, and ended up getting a coordinator role at a hospital. And that's kind of what started my administrative career off. And throughout the years, ended up working in various administrative roles that ended up in the space of telehealth. And I worked at Children's Hospital Philadelphia, and then Nemours DuPont Hospital for Children. And then kind of flipped the script and went from pediatrics to geriatrics, and ended up working at West Health for about 5 years. And West Health was established by two billionaire philanthropists that were focused in on the cost of healthcare and care for older adults. They saw very early on that they needed some support in explaining to hospitals, healthcare organizations, and particularly the post-acute long-term care space, how telehealth could support care for the older adult in those environments. And from there, ended up trying out the startup world. And, I'm originally from Philly, and then moving out to California, all I heard of was startup this, startup that. And I became enamored with the idea of working at a startup. I came across this company as I was looking for a medical device that did telehealth that could help me take care of patients at a clinic that I helped support. And connected with MedWand, and we had stayed in connection. And they said, "Hey, Mike, when we get FDA clearance, you want to join us?" And I said, "You know what? Yeah, let's do it." And that's how I ended up kind of at a startup. I spent my entire career at nonprofits, and it's a completely different space being in the startup for-profit world. Whole level of understanding that I never had, and much respect for this space.
That's awesome. That's quite a journey. And it sounds like you've worked with patients from the spectrums of age and healthcare from children's hospitals to geriatrics. And my understanding from meeting you at the International Society for Telehealth and E-Medicine is that you're very much in a geriatrics niche right now.
Indeed, looking back, I had the opportunity of being in the pediatric space and the geriatric space. And the thing that I recognized out of the gate was just how much more support, funding, acceptance, change management. Let me restate that. I've noticed that there's a real big difference from pediatrics to geriatrics in that there's a lot more funding and support and the acceptance of needing to change how you do and deliver care in the pediatric space versus the geriatric space. And it was kind of a sad learning and awareness for me that the older adult space, they don't have all the supports that the pediatric space gets. I remember being part of development activities, and development's another way of just saying fundraising in pediatrics. And it seemed like the money was just flowing in. Everyone saw the opportunity and they felt compelled to donate and give to the pediatric space. But in the older adult space, it's a lot harder to get the funding, the support, and in general, just how you make things move in the care delivery model is a lot harder, I think, in the geriatric space.
Yeah, Michael, we're very much focused on healthcare equity in the activities we do. And I think what you're doing and what you're bringing up is that certain groups suffer from the issues of inequity more than others. And part of creating equity is creating the recognition and bringing the resources that you need to bring healthcare equity to those places. So tell us a little bit more about what challenges you see in trying to work with telehealth in the home and telehealth in the geriatrics populations.
Well, one, I think, and this is common for a lot of different, it could be any age group, but in particular, I think the older adults that don't have access to broadband or internet, I think if they don't have that infrastructure support, particularly in rural communities and communities that aren't socioeconomically as well to do, they don't have the best internet connectivity. And if you don't have the internet connectivity, you're pretty much dead in the water when it comes to telehealth, unless the internet comes to you. And there are models that we could talk about where the internet comes to the patient with like a telehealth facilitator, if you will. But the main challenge outside of infrastructure is having boots on the ground that understand the older adult in particular, how they learn and integrate information, how they speak to them, because some people still feel like they need to talk to the older adult using kind of like this elder speak, and that really diminishes the impact of like your communication, and like you're not giving that older adult the respect and the dignity that they should have in communication. So even equity in how you communicate with that person. So there's a lack of personnel that really understand the older adult, the community, and the culture that they come from. And then if you kind of overlay the need for an understanding of just a little bit of understanding of technology and how it works, it becomes a very, very hard nut to crack to support this community, particularly in these rural, very spaced out regions.
Yeah, I heard a lot of interesting things there because it really sounds like, look, geriatrics is an at risk population for issues with unequal access because they're older and they don't get the same recognition and the same amount of motivation from the general public for funding. But I'm also hearing that this population is also heavily intersecting with economically disadvantaged populations and rural populations and people being in areas without internet and broadband connection.
That's true. And all those create this very kind of complex situation in which you have these older adults that are living with more disease processes. Some of them, thankfully, are living longer, but they might be more unhealthy. So, managing these chronic diseases, making sure that they have access to care where and when they need it is very challenging. So, you need to come up with strategies that are, I think, still atypical to what our healthcare system in the United States is used to providing. For instance, like having a person go to the patient's home. That used to be the way business was done. Decades ago, maybe even 100 years ago, the doctor would come to your house, with a little bag. And over the years, we created these hyper centralized organizations, hospitals and health systems and clinics. And we essentially forced the patient and their caregivers to go to these centralized locations, no matter how far away they were or how inconvenient it was. And inconvenience is putting it lightly. Some of these older adults have a hard time just getting out of the house. And one of the reasons that they're getting that way is because they haven't gotten enough preventive care. Like, things have gone so long that things are starting to get worse for them. So one model that has been really successful and some entrepreneurial organizations are doing is that they're sending out EMT-like or emergency medical technician type or paramedicine or nursing assistant or medical assistant to the person's home and literally beaming in the consulting provider, whether they be a physician assistant, nurse practitioner, or a doctor. And that's helping these patients get access to care sooner than they would if they had to go there in person. And these entrepreneurial organizations are trying to get really crafty at how they pay for services like that. And we can talk about some of those models that I'm seeing develop as far as reimbursement. But hospitals and healthcare systems are not used to taking the care out to the patient. There are some models that are developing, thankfully, like hospital at home and home health agencies. But there's still too few and far between, especially in the rural communities.
You've been in healthcare a long time, 25 years by your report. You've seen healthcare carried out in this in person only scenario for a long time. Our audience will be mixed, right? There'll be people listening to this that are in healthcare and some that are not and are learning about health equity and healthcare in general. Tell us more about what you've seen about how in person healthcare works and maybe what the factors, political and economic, that have led to this model of centralized healthcare at the convenience of the medical center, not necessarily the patient.
let me tell you a story about direct primary care real quick. So part of my role here is to understand all the different market sectors that we could be successful at. And I had heard of direct primary care, which for your audience is, imagine you paying a monthly subscription for access to like a certain set of doctors or healthcare clinic outside of your insurance. Or if you don't have insurance, you could just pay for a DPC provider. And it ranges anywhere between, 35 to 150 or 350 a month, depending on the type of doctor you have and how big your family, how big your family is. So I went to this direct primary care conference and I was shocked. I was shocked at just how happy the providers were. They were docs and PAs and nurse practitioners that mostly had been in the traditional healthcare system. And that traditional healthcare system made them, just because of the reimbursement model, see patients at volume. So the more patients you see, the more money you make. And if you've ever been a patient in this space, you know that you're seeing your doc maybe for 7 minutes to 15 minutes, particularly in these healthcare systems that, hey, come on in because I'm going to see you. You're waiting for me in my office because I'm still finishing up with the patient. So every 15 minutes or every 10 minutes, I'm seeing a new patient. And those poor providers, they would go through the grind. And that's how they described it. And then they would have to spend hours at the end of their day catching up on documentation so they could bill appropriately. Well, at this particular DPC conference, there were about 200, 250 of these providers. So happy they had left the traditional space because now they could slow down. They can see their patients. They don't have to worry about billing unless they want to do billing, billing those CPT codes and making sure that they're seeing, making sure that they meet all the requirements for those codes. I say that because they're able to really spend time and connect with their patients. Something that I think all providers ultimately really want to do. But the way the machine has developed over the decades, it has not allowed for that. And these providers that have taken a chance, they've left the comfort of the system and they're out on their own, developing their own reputation and trying to get people to sign up. And they have panels anywhere from 200 up to 1,500, maybe even 2,000. And they are much happier because they are able to provide the care that they want to provide at the pace that they want to. And I say that because most of us in the United States aren't experiencing these happy providers, the ones that could slow down and really get to know you, understand how you want to live your life, what your goals are, get to know your family a little bit. I'm seeing them for more than 15 minutes a year. So I think we're all suffering because of the way the system is designed right now. And I think these new models, these entrepreneurial providers, I think that message is going to start to permeate throughout the provider community. And hopefully that'll influence the machine that we're all pretty much part of to change.
So, Michael, these new models are actually the old models. We're just going back in a full circle, right, to where we came from.
Isn't that amazing?
But you're right that there has been a corporatization of medicine in between. And you talked about CPT codes, which are, for the audience, coding and billing codes that don't um, put a high value on the time the doctor spends listening and figuring out what is wrong with you, or just giving you the education you need. But they put a very high premium on things like tests and procedures, which has put everyone in this place of high volume, high testing, high cost medicine.
Indeed. Isn't that the sad thing? The incentive model for the providers in our healthcare system now is reversed. Instead of spending more time with the patient, understanding them, educating them on some preventive care, it's like, hey, come on in. Let's just kind of like, let's sign you up for these tests, and hopefully we catch something if we find it in these tests and these 15 minutes that we spend together.
Yeah, that's amazing perspective. We're going to take a break, and when we return, we will talk more about what the alternatives are for both equity and for better care and better healthcare for our clinicians with our guest, Michael Kurliand.